Thank you everyone for listening to this video today. Today what we're going to do is to go in a bit deeper level in terms of talking about connecting Southwestern Ontario and Ontario generally. Last week we talked about the Canada Health Info Way and what the national guidelines were and what the national directive was. And so now we're just going to go deeper into to Ontario. Specifically, I'm going to describe the initiatives of eHealth Ontario and their perspective on healthcare and what they're trying to achieve by their mission and their vision. I'll highlight their document that guides what they're doing. It's called eHealth Blueprint, and it will describe the key drivers behind their initiatives and the benefits of the initiatives and how they're going to improve communication through the EMR, the electronic medical record. I'll also define and describe the e-notification service, the e-screener service, the telehome care service, the surgical waitlist deposit repositories, and the resource matching and referral service. Those were briefly mentioned in the last video that you saw last week, but we'll go into them a little bit deeper today. We'll describe the Connecting Southwestern Ontario initiative and illustrate the benefits of the electronic medical record for patients, clinicians, and the system overall. There are also some challenges in Southwestern Ontario to get everybody connected, but we'll talk about how CSWO is trying to support clinicians and hospitals and communities to overcome those barriers. Finally, you'll have an opportunity to watch a couple of YouTube videos, and then we'll debrief. I will describe and through the debrief some of the benefits and challenges with each of those videos. Next slide, please. So, as you recall, Canada Health Info Way was the national organizing body for the EMR and EHR initiatives in Canada. The Ministry of Long-Term Health and Healthcare is a provincial body. It has 14 local health authorities, or local health integration networks, as we call them in Ontario. In other provinces, they're called local health authorities, but similar structures. So we have 14 of them in Ontario. They are not-for-profit organizations, and they're responsible for disseminating the money from the healthcare dollars from the federal government through the provincial government and then to the local health integration network, and then from there to the hospitals or to family docs offices or to the community care access centers. So they are responsible for all of that funding, the planning, and the integrating within Ontario. Our local health integration network is called LIN2. The Windsor, Erie, St. Clair area is LIN1, and so on and so forth. It continues up north with the Grey Bruce as LIN3, and then further going out towards Toronto. eHealth Ontario is an independent agency of the Ministry of Long-Term Health, and it's created to implement an electronic health record across Canada, or across Ontario. So the local driver is the eHealth. Where it's funded from is from the local health integration network. Their perspective on healthcare is that the patient is at the center of the system. So everything we should be doing with electronic health record system is to improve patient care. Whether that is faster communication, quicker access to lab results, quicker access to imaging, whatever it looks like, it's to improve the patient care that we deliver to patients and the patient's experience themselves. As you recall last week, I mentioned just when a patient goes into the emergency room, they have to communicate the reason why they're there and their demographic information at least 5 times to, to the triage nurse, to the registration clerk, to the nurse when they get into a bed and emerge, then usually a medical student or a resident, and then finally a consultant. So at least 5 or 6 times. So we want to improve that experience for patients. We do want to check in and make sure that there hasn't been anything that was missed or changed, but we have the foundation with being able to look up information electronically. So we have lots of people interacting with the patient, and with that example in the emergency room, not only do you have physicians and nursing staff, you might also have a respiratory therapist, you might also have a porter, you might also have a physiotherapist. So there's lots of people who are interacting with that patient and documenting on the patient and asking them questions and treating the patient. And they often are siloed in their information. It's not all put into one system yet. The physiotherapist, for example, would have written out assessment notes. The occupational therapist would write out assessment notes. They're not yet electronic, at least to my knowledge, in London and the London hospitals. So they leave a trail of information about their health care, which is often recorded and stored individually by providers and not accessible to all the people who are caring for the patient. So what the goal is to make sure that we're all connected and the information is free-flowing. Often these sources, as I said, are not connected and not shareable. Sometimes it's because it's paper versus electronic, and sometimes it's because it's different systems. We have a mental health care system where they have to, the providers in mental health, they have to enter information into a repository or database, and that yet isn't compatible with PowerChart that we use here locally in London. So there's two systems that store mental health care information. We have to get better at integrating and interfacing those systems. Next slide, please. So the e-health landscape. We have healthcare services, which is the overall umbrella, which is made up of primary care, so your family physician, acute care, which would be your hospital, long-term care, and all of the allied health or ancillary services, which is another name for allied health, that's in the community, such as physiotherapy, such as occupational therapy. So those are some examples. Nutritionists, speech and language pathologists, ophthalmologists, all kinds of different kinds of healthcare providers. The e-health initiatives is to link care by focusing on the electronic health records. And so that's the circle there in the middle. Next slide, please. The mission of eHealth Ontario is to achieve excellence, not mediocre, excellence. Excellence in healthcare by harnessing the power of information. The more information available to people who need it and are approved to access that information, the better the patient care and the better patient experience. So it's excellence. It's not mediocre or good enough. We want to be the best, and our patients deserve the best. Next slide, please. The eHealth Ontario vision is a division of the Canada Health InfoWay, so you'll see some of the information repeated. It only makes sense that the provincial body would have the same vision and mission as the national body. So they would like an electronic health record for 100% of Canadians. As I mentioned last week, that means any Canadian, regardless of socioeconomic status, regardless of whether they're a Canadian national, or whether they're an immigrant, or whether they have housing, or they're unemployed, or whether they're homeless. We want 100% availability for all of our patients. We want to connect primary care and ambulatory care. So primary care being physicians' offices, family physicians' offices. Right now, as I said last week, through Spire, there is an initiative to help people get connected, but it's still spotty at best. It's not fully integrated. There aren't all of the physicians' offices able to access hospital information or long-term care information. So the long-term care facilities like the Dearness Home, etc., they're not yet connected on an electronic health record. Nor do they have an electronic health record implemented sometimes at their sites yet. There just hasn't been the focus, and there hasn't been the money directed to that area. But with an aging population and more people residing in long-term care, then the focus is now shifting, because it doesn't have to be in a hospital all of the time. I was looking today at our hospital, and we're at 125% capacity in our division of medicine, which means we have too many patients for the number of beds that we have. And when you go deeper into the numbers, I also noticed that we're sitting with 26 patients who are deemed to not need acute care. They're deemed to be alternate level of care, which means they don't need acute care, but they can't go home. They need to go into a long-term care facility. But there aren't the beds in the long-term care facilities, so they're still here in the hospital. So they don't need the care here, and so it's expensive care. So we want to make sure that we do get them eventually into the beds, but we need that information to flow to the long-term care facilities to be able to properly look after them. The hospital information systems with CPOE, as I mentioned, that is computerized provider order entry. The more orders that we have in the system, the more knowledgeable the nursing staff and all of the other folks that are caring for the patient are about what is the direction for the patient, what's the care plan for the patient. So the more the orders are in there, the more prescriptions, the medications, the lab orders, the radiology orders, any other assessments that get into the system that is able to be viewed by all and not just one person if they're writing it out, the better the care for the patient. It also allows that immediate decision support for the patient, for the providers that are caring for the patient, and also some long-term decision support. So if people are doing some research or continuous and quality improvement projects, they can also data mine the data and help use it to improve care. And lastly, the patient portals. As I mentioned, our oncology division will be piloting a patient portal this coming fall. And so that is a portal that will allow patients to book their appointments online, to see their appointment times, to be able to look at lab results, to look at any communication they've had with the office in terms of emails, etc. And get a better patient experience, a fully informed patient regarding their upcoming care. Next slide, please. The eHealth Ontario vision for business systems, as we mentioned, was in the areas of public health, chronic disease, wait times, patient self-care, and performance management. In terms of public health, their focus is on pandemic management. The examples I gave last week were SARS and H1N1. So they want to make sure that they're able to have data that informs them if there's a pandemic that breaks out. They need to know how many Canadians have been immunized, and if they have been immunized, with what. Have they had their hepatitis B and C? Have they had their flu shot? So they're able to then be able to care for the patients better and knowing what their level is at right now. Treating a patient who has not been immunized might be very different than treating a patient who has been immunized, depending on their condition. The business systems for chronic disease management focus more around things like rheumatoid arthritis, diabetes, heart failure, and oncology. Oncology can be a chronic care. It can be a chronic condition. It also can be in a very acute condition, but for some people, they can have cancer for many years of their life. So their focus is on helping to improve chronic disease management. We also want to decrease our wait times. So the business systems for wait time management. We want to allow electronic referrals so people can look around and see where is an open MRI time. Is that at St. Joseph's Hospital? Is that at University? Is that at Victoria? If they're willing to travel and have the ability to travel, we should allow them to do that. With an electronic referral, we might be able to get that quicker. Also, that I give the example of MRI, but it could also be a referral to a specialist office. So it could be a neurosurgeon with somebody with, with degenerative discs, as I mentioned my husband last week. We specifically went to one surgeon was based on a recommendation, but if there was a need to get into a neurosurgeon's office earlier, if the e-referral system was there, the family doc could potentially get someone who perhaps was new to London in neurosurgery and perhaps is now taking new patients. So if we had that available, the current system, the family doc types out a note, it gets faxed over to a neurosurgeon who is accepting patients, and first of all, the family doc has to look up on our website who is accepting referrals. They get their fax number, they fax over that referral. Then that neurosurgeon or that specialist receives that fax, they decide whether to accept the patient, they book them an appointment, and they fax the appointment back to the family physician, who then sends out a letter to the patient. A very inefficient system, and it takes a long time. So e-referrals can assist with having that process streamlined more expediently. Patient self-care. Patients want to care for themselves if they are able. I mentioned the burn that I have on my leg. I was able to care for myself after a certain point. I didn't need to having my dressings changed at a certain point. I was then available and able to do it myself. They provided the materials, they provided the gauze and the saline solution, but it did come to a point where I was able to care for myself, and that was more efficient. I didn't have to travel in to see a nurse to be able to have to do that. So people want to have some care in their home and be able to do it sufficiently for themselves. And then performance management, again, another goal of eHealth Ontario, also a goal with Canada Health InfoWay, is to have a sustainable system that's workable, that's easily accessible, yet allows for patient privacy through the HIAL, the access layers, and also to have sustainable patient care delivery. So we want to make sure that there aren't downtimes. Next slide, please. The eHealth Ontario 5 priorities. Again, consistent with Canada Health InfoWay. So some of these are repeated. We want to make sure that there's a baseline electronic health record and public health infrastructure in place across the country. So yes, across the country, but also specifically in Ontario. So connecting all of those places like hospitals and long-term care and community care, family physicians' offices. The second priority is to unlock additional quality and safety benefits by enabling decision support and communication across the continuum. So if my family doc has the same information as my physiotherapist, which has the same information as the person who's fitting my orthotics, who has the same information as my chiropractor, I'm going to get better care. Perhaps less testing, perhaps there isn't the need for the constant imaging of the back or whatever it is, and the information is going to flow across all those healthcare providers. It's not there yet, but we're getting there. A registry and reporting system of wait times. So if we're registering when the patient is needing a referral, and then all the way to when the patient receives the surgery and the follow-up care after the surgery. If we can track that, if we know it, we can see it, we can improve it, and we can find ways to improve it. But it's hard to improve systems if you don't know what you're working with. So we need to collect the data, review it, analyze it, and come up with strategies to improve it. So those registries will be helping to see that. It also ensures public visibility, so the public now knows why there's the wait times. And that often will decrease the myths that go on with long wait times. And it's quite often about resources, about the number of either physicians to do the work or the time to get an MRI to be diagnosed with a certain condition in order for them to book the surgical time. The fourth one is to facilitate improvements in self-care, creating those patient portals with access to electronic health records, information, and other basic information and self-care tools. So by the other basic information, I mentioned last week the evidence. If I wanted to know why the physician is suggesting this kind of physiotherapy, active versus passive, I could look up the research on that without having to go to Google. I could get really good validated research on that. This is why they're recommending this. And people want that. People want to be able to know why. Why are you recommending this versus that? The last one is to trial more advanced functionality to meet the high priority system needs. So create an integrated triage scheduling and referral model solution with case management priority assessment across the continuum. So if a family doc is referring the patient to a specialist and has a mild condition but deteriorating versus another patient who has a severe condition and is actively deteriorating, the appointment times may differ. And so therefore one patient might get in quicker than the other. So the triage level of one would be different than the triage level of the other. So creating a model solution that demonstrates also approaches to different chronic diseases. So the models are changing on how we manage chronic disease. One of the tools that we'll talk about a little later on is the telehealth. So people are able to speak to a nurse when their blood glucose drops or is elevated. And there's able to be corrective measures taken in dialogue with the nurse, because it's within the nurse's scope of practice to be able to perhaps just change the prescription a little bit. Mostly that would be a nurse practitioner versus a registered nurse versus a registered practical nurse. That would be their role, but they could interact with that nurse practitioner over the phone or over video conference. Next slide, please. The eHealth Ontario Blueprint is a document that's guiding this work across Ontario. So as I mentioned, it's on Fanshawe Online. I encourage you to take a look at it. It goes a little bit deeper into each one of these areas and gives you some examples. So the technology to connect and communicate is one of the first areas of focus. That includes the hardware, the software, and the networks. It includes focus and collaboration with the vendors of all the various software programs. It doesn't dictate a specific software. As long as that software is interoperable with other systems. If a facility chooses to use one system over another system, say for an example, an AGFA imaging system versus a GE imaging system, as long as they're compatible, they could choose either one of them. So the standards for what makes things compatible is set by Canada Health Infoway. We also want to strengthen the exchange of patient-client resident information by way of providers and individuals. So we want to allow individuals to be able to indicate what is going on with them right now in terms of how they're feeling, perhaps their temperature. They have that information themselves, so it doesn't need to be necessarily repeated. If I'm on the phone to the nurse practitioner and I have a fever and perhaps a sore that seems to be weeping, they may increase my antibiotics or put me on a new antibiotic. And so we want to make sure that that information is free-flowing. I don't have to wait till I get an appointment with the nurse practitioner. They take my temperature, they take a look at the wound, and then they prescribe the antibiotics. I could do that over the phone or via video conference. They could even take a look at my wound. The other focus is to explain the use of technology to enhance hands-on care and leverage human resources. So if people have the information available to them and readily available, then perhaps they could act in a more timely manner. And that would allow us to make sure that the right people are doing the right work. So as I said, it may not need to be a physician that sees the patient. It might be the nurse practitioner. It might even be the social worker. Right now there's a lot of focus on mental health, and patients tend to gravitate towards psychiatrists or psychologists, where maybe their issues are really socially driven, and might be okay just to come and see a social worker and to work out their issues with the social worker. So allowing the right human resource person to be able to address the care, because we have more information available to us. We also want to implement decision support with the electronic applications. So be able to extract data, look at data, and have informed decisions made. A lot of folks will go on based on past medical histories, which often informs the current medical condition, but sometimes it doesn't. So having the data available and readily available for people to look at can help make an informed decision, perhaps even with the evidence that's out there in the community right now. One example I mentioned last week is now there's evidence to say that there's no longer a need for an x-ray when a patient comes in with mechanical back pain. So there's no need to radiate them. It's mechanical, it's not disc related. And so that is new evidence. And so if we had that information available, that it was diagnosed as mechanical and not related to deteriorating discs, then people wouldn't need to order that radiology exam and thus radiate the patient. So we want to also constantly improve our navigation tools and the information available within them, and ensure that the information is accurate and up to date. Next slide, please. By simplifying information access and sharing, eHealth provides the following benefits. There's improved care for the patients, improved safety for the patients, If we know that the patient's on X medication and we want to order Y medication, if there's an interaction, we would have that information available to them. Or we would know what the patient's allergies are. So if you're ordering amoxicillin for a patient and they're allergic to penicillin, we wouldn't order it because, of course, it would interact negatively for the patient. We want to improve security for the patient's information. Patients want their information to be private and confidential and only released to those who they deem necessary to have it and who are approved to have that information. We want improved support. Improved support for the patients, for clinicians, and families. We want improved practice efficiencies. We want to minimize waste. We're dealing with our own healthcare dollars here. So we want to make sure the care that we're providing is effective, it's efficient, and it's not a waste of Ontarians' dollars. The goals, next slide please. The goals of the electronic health record are to provide a patient-centric solution. We are moving to this whole concept of patient-centric, patient at the center, from physician-centric. We were in the past, the physician was seen as the expert, and everybody looked towards the expert. And to a degree, we still do that, for sure. But the patient has a lot of information, and the patient wants to be involved. So there's a bit of a shift to involving the patient in collaboration with the physician or the medical team. So we want a patient-centric solution to the challenges currently facing in the province's health sector. As I mentioned last week, we involve patients. We have a patient advisory committee, and most of the initiatives that we do that are large-scale changes, not the small-scale changes, but the large initiatives, we involve the patient advisory committee, or at least a few patients, an adult patient and perhaps a pediatric patient who is perhaps maybe around the teenage years. We are doing that right now with a large initiative with mental health, and we're just looking at the patient's experience in mental health care because their survey data has told us that there are some myths that teenagers have about accessing mental health care in hospitals and in the community. And so we want to take a look at those myths and try and either debunk them or to find ways to improve them and turn them from a myth and not a reality. Electronic health records also are the means for diverse healthcare systems and data resources to share information. Very diverse systems. So from the patient demographic information to the cardiology information to the imaging system to the lab system, all of the various systems need to have the integration to the medication systems that are out there, the community care access notes. If I've been seeing a nurse for patient care, or perhaps I've been seen by a personal services worker in my house checking in on me, or a nurse doing wound care, we want to see the notes that they're making on the progression of my care. So again, it means that they need to be standardized and interoperable. We only want authorized users to have the access to the information, and the patient deems who gets access to that. There is what we call informed consent. So if I'm coming to a family physician's office, I am assuming and giving consent to all the people in that office to be able to look at my information. If I don't want people to look at my information, I am allowed to say, I just want this person, perhaps the physician or perhaps the nurse or what have you, being able to look at my information. And not only that, you can also lock down portions of your chart. If there's some information in your chart that you don't want people to see, you can request what we call a lockbox, and we would lock access to that information through the hospital information access layer. So that is available as well. Efficient way to request information from different sources and input information into designated data services. So we want that all to be very efficient. Input information from different services. I referenced Clinical Connect last week. Clinical Connect is the viewer that people pull information from the various systems, from various hospitals, from medication systems, etc. And the data sources, designated data sources, are those registries where people are inputting the wait times for hip replacements, for knee replacements, for neurosurgeons, for people with acute back pain, etc. Because we want to improve those. Next slide, please. Ontario's eHealth Blueprint also is the document that informs the electronic health record planning and the delivery of that planning, those plans for the province. It defines the elements required to realize the goals of an electronic health record. And it provides that framework for people. It's standard, they're guidelines, it's the document that guides what people do in Ontario. It describes the architectural principles, the patterns that will be employed in order so that we can have effective and efficient solutions. It's built on the foundations of making sure that we keep information private and confidential, and we have people that are compliant with those security aspects, that we have collaborative governance over those systems. So the hospitals need to collaborate with the family physicians, which need to collaborate with the local health integration networks and the community care access centers. And that we have policies and regulations about who can access what information and how that information is put together. And with standardization and with some sort of federal viewpoint on it as well. Because again, as you recall, from the Canada Health Envoy, that's where the funding is coming from, and that's where the main goals and vision originated from. Next slide, please. So why this blueprint? This blueprint is the roadmap, or your Google Maps, for you to be able to get from here to a cottage up north and you've never been there before. The simplest tool that we deploy is Google Maps. Show me how to get there, or my GPS. And so it is the GPS, it is the blueprint, it is the Google Map. It provides the tool, but also to increase dialogue. In terms of dialogue, communicating what's the current state, where do we want to go, what do we need to do to get there. It establishes a common framework and terminology, so those standards of terminology and the common framework to work towards each one of the goals. It provides provincial architecture and standards. So we describe in the document how the networks are formulated, how people go about implementing health record systems, and what standards need to be put in place in order for them to be interoperable.